Coming up on Mayo Clinic Q&A.
Part of the challenge is a lot of these defects may be silent when they're born and may come to surface as they get older, or even for our female patients, pregnancy may be the first test where we can find out there may be an underlying problem that was never really discovered.
That problem is congenital heart disease, a condition of the heart structure. 1 in 100 babies are born with some sort of issue, but advances in diagnosis and treatment can allow them to live long and productive lives.
These patients would require long-term surveillance to make sure those mild abnormalities are not causing any further stress in their heart as they're growing older.
Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. Congenital heart disease is one or more structural problems with the heart that have existed since birth. While some congenital heart defects cause no problems at all, others can cause life-threatening complications. Advances in the diagnosis and treatment in babies are now allowing individuals with congenital heart disease to live well into adulthood. Sometimes the signs and symptoms of congenital heart disease are not even evident until people are adults. Here to discuss adult congenital heart disease is Dr. David Majdalany, a cardiologist at Mayo Clinic in Arizona. Thanks for joining us today.
Thank you very much, Helena. I'm honored to be part of this program.
Well, I always say that I love to learn something, and I know I definitely can learn something from you today about congenital heart disease in adults.
Well, I'm sure we learn and teach from each other in this, advancement in the advancing medical field. We teach and learn from each other.
So my first question,
our patients teach us as well.
That's right. So David, my first question for you today is, how common is adult congenital heart disease?
That's a good question. I mean, adult congenital heart disease probably encompasses about close to 1% of all births. And as you mentioned, as the advancement in medicine and diagnosis and intervention has been prospering over the last few decades, we have a lot of these patients living into adulthood, and there's even more adult patients with congenital heart disease now than there are pediatric patients with adult congenital heart disease. So it certainly is a growing population.
Wow. And that's really interesting, because 1% may not sound like much, but when you think about all the births, 1 in 100 babies having some sort of difficulty like this is really kind of significant.
It certainly is significant. I mean, part of the challenge is a lot of these defects may be silent when they're born and may, come to surface as they go, as they get older, or even for our female patients, pregnancy may be the first test where we can find out there may be an underlying problem that was never really discovered before pregnancy.
David, in my years before only doing pain medicine, I'm of course an anesthesiologist, and I recall that many of the patients that I would take care of in the operating room had pediatric congenital heart specialists, even far into adulthood. So adult congenital heart as a specialty is a little bit newer, I think.
That's right. I mean, the training now encompasses 2 years after you're done with your general cardiology fellowship. There are several pathways you can get, appropriately trained and then be eligible to pass the board for adult congenital heart disease. So we do have a lot of providers from the adult side that trained, and then some also providers from the pediatric side that have trained in adult congenital heart disease. And I think we both help the patient overall, and then we bring different perspectives into their care, where a lot of these patients had their rapport with the pediatric cardiologist. They entrusted their life in the decision making with him, and then as they grow older, they do start experiencing the normal problems that patients get with age, high blood pressure, diabetes, coronary artery disease. So these are the things that the perspective of the adult cardiologist may kind of be a little bit more aware of in terms of testing, preventing, and managing those issues. But I think both patients can be managed with both providers, and sometimes it's a good idea for both of these providers to collaborate in the care of those patients.
That is really interesting, David. I had never before really thought about, I always thought about the heart disease as being the structural defect, but obviously as people age and people survive and have surgeries for these defects, then they go on to be adults with the other problems that the rest of us face.
That's so true. I mean, again, I've taken care of a lot of patients with, pregnant patients, and you do see sometimes manifestation of adult heart disease in addition to the congenital heart disease that we have to keep in our mind as they progress through different stages of pregnancy and delivery, and even consider future pregnancies. So it is true. I mean, a lot of our patients now, our female patients, are delaying pregnancy into the third or fourth decade, and then they start encountering some aspects of the, heart disease that we see traditionally in adults.
That's really interesting. I want to start by asking you about congenital heart defects. Does almost everyone or everyone who has a congenital heart defect end up needing some sort of a surgery to fix it? And does surgery fix all of these?
Well, the adult congenital heart disease is kind of a spectrum of issues. There are certainly some abnormalities that may be considered simple congenital heart disease, such as atrial septal defects, patent ductus arteriosus, maybe mild valvular narrowing or leaking, ventricular septal defects. So, in a lot of these simple abnormalities, and depending on how they're impacting the heart, may or may not require interventions. But a lot of these patients would require long-term surveillance to make sure those mild abnormalities are not causing any further stress in their heart as they're growing older. Now, there are certainly more complex congenital heart disease, what we call the cyanotic congenital heart disease, where patients have low oxygen levels in their blood. Those can include things like tetralogy of Fallot, transposition of the great vessels, patients born with, what we call single ventricle physiology. Those types of patients, would, rarely survive into adulthood without some sort of intervention, and actually many of them require multiple interventions through their life, and then we really need lifelong follow-up. I mean, I do encourage all our congenital patients to at least have some relationship with a cardiologist that's aware of their congenital heart disease, aware of the long-term effects of that congenital heart disease on their life, whether or not they have or have not required an intervention. And especially for our female patients that are entertaining pregnancy, if they had some element of congenital heart disease, they should certainly seek a updated cardiovascular visit, kind of get a pre-pregnancy counseling to make sure they're able to sustain the pregnancy safely and have the best outcome for mom and baby.
I want to get back in a moment to women who want to become pregnant who have heart disease, but I wanted to ask you first about a term you used. You used the word cyanotic, and I'm wondering, does that refer to what I learned in medical school as blue babies?
Yes, it is, cyanosis does, reflect what are called blue baby, low oxygen levels in the body. They may be either due to overcirculation of blood to the lungs, or meaning that we're not able to send the blood to the lungs to get oxygenated. So yes, there's your term cyanotic in simple words is mean that the patient has, sometimes they have blue lips, blue hands. They may have some unusual curvature to their fingernails if they've had long, effects of this low oxygen levels on their body.
Which sounds like it would be indicative of a fairly serious defect, as you said, that would require some kind of intervention. Right.
I mean, there are certain types. Yes, I mean, a lot of these patients with cyanotic congenital heart disease, they usually get picked up early in childhood, soon after birth, and they can know what the issue is, diagnose it, and see what's the best way to help the patient. So that, we do want to minimize the amount of months and years as much as possible. Patients or babies are kind of living on low oxygen levels, because it's kind of the fuel to the body. And if you don't have fuel, you don't really go very far, or as far as you'd like to go.
David, how do you make sure that these pediatric patients don't fall through the cracks, so to speak, when they reach adulthood and they continue to receive regular cardiac care?
I mean, that's a common issue that we encounter in our patients. Many patients have born with a congenital heart disease. They undergo an intervention or whether it's surgery or an intervention in the cath lab, and think they're, fixed. They have no further needs for cardiac surveillance. So they maybe fall off the radar of getting follow-up because they feel so good. But, feeling so good is not necessarily like a foolproof issue, because a lot of these patients feel so good until they really get to the stage where they really are in dire straits. And, we kind of scratch, how can we help this patient? Is it too late to help these patients? Do they need transplant? So I think, so part of that issue is encouraging them to have lifelong follow-up from the get-go, even as they grow, from pediatric age group to the adult group, and having a good, what we call transition or handoff from the pediatric cardiologist to the adult cardiologist, where they, discuss the patient cases, they share the records, share their course of care, so that the, person who's receiving the baton can continue that race and following with the patients. So I think education of the patient, make them aware that they've had the congenital heart disease, is the condition that's going to be with them lifelong. There are simple ones, simple versions of congenital heart disease that may not require as frequent visits, and there are more complex congenital heart disease that require maybe sometimes every 6 months instead of every year, or soon, or even sooner, depending on the case. So I think education, alerting the patients from the get-go that you've had the heart condition, certainly this requires lifelong follow-up. Please maintain your insurance coverage, because I think part of the issues that we see patients fall off the crack is, they have no access to care, they lost their insurance. It's, getting insurance is quite pricey depending on the stage of life, what their work situation is. So all these things, I think I always encourage our patients to maintain their insurance, health insurance, and then always keep tabs. If they move to a different city, find the cardiologist, say, hey, I have a congenital heart disease. Can I get an updated visit just to see? And again, it may be something we say, we'll see you every 3 to 5 years, or something you say, no, you have a little bit more complicated issue. Let's see you once a year or so. So I think educating the patient as a child, educating the parents of the patient, tell them, yes, he's an adult, he's going to be independent, but this is something that's going to be with him throughout his life and requires lifelong follow-up. So hopefully that's one thing. Yeah, no, go ahead.
No, you please go ahead.
No, so I think that's one of the things, and trying to encourage access to care. I think, now we have lots of resources online where, even if patients go to different cities, they can find, like on the, ACHA website, they can say which providers are available in the city that have expertise in congenital heart disease. So they can really be, hook up with someone who knows their congenital heart disease, and I think sometimes they get scheduled with a general cardiologist that may not be as familiar with this, the long-term effects of the congenital heart disease. So I think looking online for providers that have, board certification in training congenital heart disease in the city they move to is important, so that they can maintain, a follow-up. And it's very important for our patients to keep track of their medical records as they go from one provider to another. So everyone kind of opens a new chapter in their book, I guess, of cardiac care. So, things don't get lost, information doesn't get lost, and they have the optimal follow-up.
David, you touched on a topic which is a big concern to all of us at Mayo Clinic and nationally now, disparities in healthcare. So individuals who may not be able to maintain their insurance or may have difficulty having access to care. Do you see this frequently with adults with congenital heart disease?
Yeah, I mean, it's unfortunately, it's not uncommon that we see that. And again, a lot of these patients say, well, I saw the pediatric cardiologist, I was 16, I felt good. So I never really sought help to see anybody. Then, they're unemployed, they have no insurance. Then they say, oh, I don't feel so good, I need to see somebody. And then they just say, oh, can you pay deductible? Can you pay this? So there are financial stresses on the patient that may delay their care. And then they only come to us in dire straits, coming to the emergency room, whether it's overt heart failure or irregular rhythms of the heart. These are both very common sequelae of their congenital heart disease. So it is true. And I think, the adult congenital heart population is an underserved population. And it means there's more patients than there are providers. And then depending on where they live, some places may have one site that's 6 hours away from them that has congenital expertise. So I think as I mentioned, access to care, and then, again, unfortunately, depending on where you live, you may or may not be in an underserved area. But we did have, and I always encourage our patients, you can see us once a year or every other year, and then we can collaborate with your local cardiologist to optimize your care, especially if you cannot come in regularly to see us.
And I would imagine that lack of access to care may contribute to more complications for patients who could have been treated at an earlier stage, that perhaps you see patients who have developed complications that wouldn't have necessarily had to occur.
No, it's true. I mean, and again, in some of the more complex versions of complex version of adult congenital heart disease, a lot of our patients come when it's really too late for us to help them. We only say the only option we have for you at this stage is, considering heart transplant or heart and lung transplant or, advanced support, heart failure support devices. Had they presented to us 2 or 3 or 4 years before, we may have actually be able to fix their leaky heart valve without really causing significant, weakness of their heart when it's too late to actually do anything.
So one of the morals of the story might be don't delay care. We're seeing a lot of delay of care during COVID-19, in particular, cancer care, primary care needs, cardiac care needs,
Yes.
but clearly care should not be avoided or delayed during this time.
I agree. I mean, even now with the COVID pandemic, we've been trying to manage our patients. If they cannot come for the in-person visit, we kind of do these video visits and we can communicate with them. And if I just say, I'm concerned about you, certainly I think an in-person visit is very important because, some of the things I cannot really address, I cannot examine you to see, where you are in terms of your symptoms, the severity of the issues. We should certainly have you come back, certainly take the precautions necessary to prevent exposure as much as possible. But, it's always risks and benefits. But I think certainly if someone is not feeling very well, I usually like to see them in clinic. I like to examine them, talk with them, and then kind of share my thoughts face to face instead of being distanced through video.
But it is marvelous that these virtual visits are opening up the possibility of seeing a specialist that some individuals may not have otherwise.
No, it's true. And I think it's very important. I mean, we can have a lot of our patients have their studies done locally and they can send us the images that we can review. And then we can communicate with them and their provider to kind of maintain continuity of care and share our expertise with their local provider as well. So I think it's, from a congenital perspective, is very important. And I try to be as collaborative with their local cardiologist as possible, sharing the information, sharing my thoughts that we should do this in this study at this point. If they cannot come to see me at this point, we'd be able to order them and send us the results, and we can kind of try to rectify if any issues in between when they cannot come for face-to-face visit.
A little bit earlier, you were talking about that transition from a pediatric specialist to an adult congenital specialist. Is there an ideal age or time in life when that should occur? How does a patient know it's time to seek a new cardiologist?
Well, I mean, again, getting back that, I mean, in terms of pathways, you can get into adult congenital heart disease training. You can approach it from both someone who's trained in adult cardiology and someone who's trained from pediatric cardiology. And I think a lot of these patients usually start when they get in their teen years. It's probably good idea to tell them, you're certainly advancing in the different stage of life. Unfortunately, we don't get younger. We only get older. Time goes in one direction.
Isn't that the truth?
I usually start, and again, I usually would advise patients when they get kind of, 13, 14, 15 to start thinking about, I'm certainly, approaching adulthood. And then maybe their cardiologist says, part of the aspects of your disease may be better managed with somebody who sees regularly adult patients. So I usually think mid-teens probably is a good time to tell them, start thinking about an adult provider, maybe give them names of different people. They can, check them out online. They can check on their website about their, the qualifications and training. And then bring the records on the first visit and share with the cardiologist and kind of see, is that somebody you really want to be kind of, I always think as the physician, I'm the navigator. The patient is driving the car and I'm navigating on the side. Is that the navigator you want to navigate your car through the rest of your life? So I think, and again, I think communication between the previous provider and their upcoming provider is very important. And I usually, again, if you have pediatric, I call them, say, hey, I've seen your patient, I think these are upcoming issues we're going to deal with. And then, tell the patient and communicate with the provider this, so they don't feel like they're, quote unquote, abandoned by one provider. And then, oh, here's the other guy. Now I'm going to deal with a new person there. And I develop this rapport because, patients in the pediatric age group, they really are very bonded to the provider because they've taken care of them from baby onward. It's like, why are you leaving me alone? So I think, and again, with the aspect that pediatric cardiologists could be trained in adult congenital heart disease as well as adult providers. So we can still co-manage the patient and maybe we can collaborate on their care. And then if there's some more aspects of the heart disease that's more adult related, maybe the adult provider can give them a little different perspective or unique perspective that pediatric cardiologists may not have that perspective that we have. So I think it doesn't mean they're abandoning them. I think we can still collaborate and then different aspects can be managed by different, the provider that's maybe more attuned to see those issues.
So perhaps two very important points from that would be plan ahead and what we call a warm handoff in medicine, where
Yes.
one physician or provider speaks to another and hands off the cares to assure that smooth transition that you talked
No,
about.
it's good, and it's good to collaborate. And I mean, some pediatric cardiologists still want to hear about how my patient doing. Say, hey, I've seen your patient; they're doing fine, or there's some issues we're dealing with at this time. And I think it's in congenital heart disease, unfortunately, the population is so small. We don't have a lot of research-driven data. So seeing different providers may give you a different perspective, and there'll be multiple correct answers to the right question, whether we continue to observe or we need to intervene. You can see different providers, and 50% of them say this, 50% say that. So I think getting a different perspective is also a good thing for our patients, so they can get, they don't just get one-sided view of what their care should be.
I wanted to go back to a topic that you mentioned a little bit earlier about pregnancy. What advice do you give to women? What must they consider if they have adult congenital heart disease and they're considering a pregnancy?
Well, again, getting back to and with the advancements of medical care, a lot of these patients are getting into adulthood. And again, part of the security say, well, I feel well, that means I can get pregnant. And certainly it's a good thing that you're feeling well, but pregnancy poses different changes on the body. There's I call them physiologic and hemodynamic changes. This is a fancy word, but usually what happens during pregnancy, there's increased blood volume in the body. There's increased demands on the patient's heart to increase the heart rate, to increase the output of the heart. And depending on what congenital heart disease you've had and what the status of your heart is before you get pregnant, you're always wondering, is this patient's heart going to be able to adapt and help the patient have an uneventful pregnancy and have also a healthy baby? So, heart disease and pregnancy is certainly one of the #1 causes of maternal deaths. And in the United States, congenital heart disease comprises a large portion of the patients with heart disease during pregnancy. So I always, I've always tell patients, again, depending on the complexity of your heart disease, it's a good idea before you contemplate pregnancy to come in, have an updated visit, let the heart doctor listen to your heart, maybe do some basic imaging like ultrasound imaging of the heart, EKG, maybe an X-ray. And again, depending on the results, whether we do stress tests or other imaging like CAT scan or MRI, just to make sure your heart is in tip-top shape before you get pregnant and you're able to sustain a pregnancy with low risks to the mom or low risk to the baby. And again, some patients just say, we just need to see you once or twice during pregnancy. Some patients, they're more complex. So we need to see you, maybe 2 or 3 times in the first and second trimester. And as you get to the latter stage of the third trimester, where the highest demand on the heart during pregnancy are occurring, we want to make sure you're able to adapt and your heart is adjusting appropriately. Yeah, go ahead. I mean, another point is that, certain medications are safe to take when you're not pregnant, but unsafe when you're pregnant. So we certainly want to review the patient's medications. We want to make sure they're on medications that are safe to maintain, for the pregnancy and not any causing effects on the baby. Big issue would be some blood pressure medicines like ACE inhibitors are not safe. Cholesterol lowering medicines are not, generally safe. Blood thinners, we certainly have to discuss what's the optimal blood thinning regimen if someone is on a blood thinner, if they have prosthetic valves and so forth. And issues like, enlarged aorta, aortic aneurysms, connective tissue disorders, these are other issues that we kind of discuss with the patient to kind of get a better feel of what the risks are to proceeding with pregnancy and what are the risks to the baby, because congenital heart disease does have a genetic predilection, and there are certain types of congenital heart disease that may be, 50-50 chance that their child may have the congenital heart disease or something similar to the parents. These are things we kind of discuss with the patients prior to get pregnant, becoming pregnant. And then we can say it's very important that we kind of follow you so often, because a simple disease would be not so often. More complex disease, especially in later stages of care, will be more frequent, maybe every few weeks. And one of the programs we're doing is kind of having the adult congenital heart disease specialist or cardiologists that have experience in pregnancy and heart disease work along with their maternal fetal medicine. I mean, the obstetrician that's taking care of high risk.
I was just going to ask you that.
Yeah.
I would imagine that it matters what obstetrician you have and where you deliver your baby.
Right. So I think communication between both providers is very important, because both shed different perspectives, safety of the mom, safety to the baby. And certainly here at Mayo Clinic, we're trying to work so we can have a combined clinic so we can see patients ideally at the same time, and kind of give them our perspective from both the cardiologist, congenital heart disease specialist, as well as the high-risk obstetrician.
Whole person care.
Yes, team effort.
That's great.
I mean, I think, and the other thing I would recommend, a lot of these patients with congenital heart disease certainly seek expertise in the tertiary care sector, because their care is not just managed with the cardiologist and the obstetrician. I think sometimes we need to seek the advice of cardiac anesthesia and particular obstetrics anesthesias, and if there's issues in terms of for the baby risks, fetal risks. Usually we have our patients have a fetal echocardiogram done around 20 weeks of gestation. To have a strong pediatric team, neonatology, intensive care unit team, cardiothoracic surgery team, or even our colleagues in the catheterization lab, because patients or baby may need an intervention sometime, whether it's during the pregnancy or soon after the delivery. So seeking care in a tertiary care center that has all those expertise is, I think, another way to optimize the care during pregnancy and minimize the risks for both mom and baby.
So often we talk about research that's ongoing as well. And I'm just wondering, is there any ongoing research in adult congenital heart disease?
It is. I mean, it is. We are certainly part of it. We set up our database, and I think part of the, we were part of the international registry of patients with heart disease or congenital heart disease during pregnancy. So we do share that information with the international registry, so that we get to learn more. The more patients we take care of, the more our knowledge base will get better, and we can certainly make better decisions. And I think having multi-center research projects is very important. Again, as we mentioned, if it's 1% of the population has congenital, or close to 1% has congenital heart disease, if we combine the numbers of the different patients with different diseases from different centers, we can certainly have a bigger number, so you can get, again, a more educated decision to help guide the care of these patients long term. So multi-center care, international registries, and sharing the research information is very important for our this specialized patient population.
Well, what an interesting area of medicine. Thanks for sharing with us, David.
Thank you very much, Elena. Thanks for having me.
Our thanks to Dr. David Majdalany, cardiologist at the Mayo Clinic in Arizona, for being here with us today to discuss adult congenital heart disease. I hope that you learned something. I know that I did. We wish everyone a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.